Welcome everyone to today's webinar brought to you by Know Diabetes by Heart, a joint initiative by the American Heart Association and the American Diabetes Association. I am Justin Ishufo. I am an endocrinologist and an epidemiologist. I'm associate professor at Johns Hopkins School of Medicine. And today we are joined by two additional experts who will translate findings from the American Heart Association scientific session that took place a few weeks ago in Philadelphia. And today's panel presenters include Dr. Sadia Khan, who is a cardiologist and also an epidemiologist. He's a professor of medicine at the Northwestern University Feinberg School of Medicine. We also have Dr. Tiffany Powell-Wiley, who is an Earl Stadtman tenure track investigator with a joint affiliation with the intramural research programs of the National Heart, Lung, and Blood Institute and National Institute of Minority Health and Health Disparity. She's an adult endocrinologist and also an epidemiologist. So we will be hosting a Q&A session at the end of today's presentation. Please use the Q&A feature to submit your question. We will try to address as many questions as possible. Now, let's get started. I'll pass it over to you, Dr. Tiffany Powell, to review some of the key findings from the scientific session. Dr. Powell-Wiley.
Thank you so much, Dr. Ishiofo, and thank you all for being here today. I'm excited and have the pleasure of talking about the session related to the late-breaking trial that was presented at AHA on semaglutide, or the SELECT trial, looking at the effects of semaglutide on cardiovascular outcomes for patients with overweight or obesity, but without diabetes. And so the session that went into a deep dive about the SELECT trial focused on three main areas. The first was a presentation by Dr. Donna Ryan, one of the SELECT trial steering committee members, who really set the context for the study. She talked about, of course, the global epidemic of obesity that those of us in cardiovascular medicine and endocrinology and many other specialties are dealing with, but also the fact that we really know about GLP-1 receptor agonists as being a potential treatment. Before the development of the SELECT trial, we really had data to suggest that GLP-1 receptor agonists could reduce cardiovascular events in patients with diabetes. But the SELECT trial really became the first trial to focus on patients without diabetes. And so setting that stage, it really highlighted the need for understanding how semaglutide and other GLP-1 receptor agonists might be utilized in patients with cardiovascular disease and overweight or obesity. The other speakers were also members of the SELECT trial steering committee. Dr. Michael Lenkoff was the second speaker, and he went through the findings from the trial and highlighted the important finding of the fact that semaglutide showed a significant reduction in the composite endpoint for the trial, which was a reduction in cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke in the patients who were in the trial. The trial was a multinational trial. It occurred over 41 countries and randomized over 17,600 individuals, again, with cardiovascular disease, but without diabetes. The average body mass index in the trial was in the in the obesity range, but to be in the trial, the BMI had to be at or above 27. And after treatment over about 40 months in the trial, there was a 20% relative reduction in the all-cause or the composite endpoint of cardiovascular death, myocardial infarction, and stroke. The trial also showed a significant reduction in mortality, but this did not reach the level of significance that was set by the Data Safety Monitoring Board to show a reduction in a relative risk reduction based on the statistical plan. And so there, but all of the endpoints that were evaluated trended in the right direction with the trial. And so this really was a landmark trial in really showing the role of GLP-1 receptor agonists and semaglutide in particular for those patients with cardiovascular disease and without diabetes, but with obesity. One of the things that came up in the discussion as the next speaker, Dr. John Dienfield, talked about some of the findings from the trial, but also put the findings in context. It was really striking how the curves for those patients who were treated versus control patients, how the curves separated very early in the trial. And the question becomes, what are some of the mechanisms by which semaglutide really lowers and reduces cardiovascular events? And those are studies that need to happen and are ongoing, looking both at this data from this semaglutide trial, but also other studies of GLP-1 receptor agonists. Dr. Dienfield also really put into context the effects and the potential for the treatment of obesity as a cardiovascular risk factor and treating obesity in the context of cardiovascular disease. He really put that in the context of how that will shift our not only our armamentarium for treatment of cardiovascular disease, but also shift how we think about treating chronic disease for our patients in the healthcare system. And I think one of the really important questions that came up from both the speakers, but also from questions from the audience is really thinking about how do we address the health inequities that are related to obesity, the inequities in who is at risk for obesity, who's most affected by obesity and its and the related cardiometabolic effects. And so the question becomes, how do we make sure that those who are most impacted, particularly under-resourced populations or minoritized populations, how do we make sure that that those populations benefit from what we're learning about GLP-1 receptor agonists as a treatment for cardiovascular disease and obesity? And so I think this has been a big part of the excitement of AHA 2023 and really thinking about obesity in the context of cardiovascular disease treatment. And so this will be a trial that will continue to garner much attention, but also new studies to really understand what are the next steps in using GLP-1 receptor agonists in our treatment of cardiovascular disease and obesity.
Thank you so much, Dr. Powell-Wiley. If you could summarize the main takeaway from this session or the main activation for one's practice, what would that be?
So from as far as a main takeaway point from the SELECT trial, it's important to understand that the patients in this trial were those with established cardiovascular disease. These are patients who had had a cardiovascular event or had a history of a stroke or peripheral artery disease. And so, and as well, of course, they had to have overweight or obesity to be in this trial. And so this shows us right now that we can consider adding GLP-1 receptor agonists to the treatment for patients who are treated already with statins and other therapies for cardiovascular disease. So this is another tool in our toolkit for the treatment of patients with cardiovascular disease and overweight or obesity.
Thank you again. Now I will take a moment to share some of the key findings of one of the sessions that I had the privilege to attend. And the session was entitled Diabetes and Heart Failure, New Mechanistic Insights and Therapeutic Strategy. There were a number of speakers on this session. The first speaker was Dr. Van Spal from Canada, and she elaborated on the burden of diabetes and heart failure globally. She shared some data from the global burden of disease showing that over the years, both the burden of diabetes and heart failure have been increasing so much so that based on the most recent data, about 500 million people in the world with diabetes. And among those 500 million people, about 10% of those people have heart failure, which corresponds to an absolute number of about 50 million people. And then she went on to share some inpatient data showing how frequent diabetes is among people who are admitted for the first time for heart failure. And she highlighted the fact that in a Canadian database, approximately 80% of people with first hospitalization for heart failure actually have diabetes. And conversely, among people who are admitted to the hospital for diabetes, there's approximately 11% of those people who concomitantly have heart failure. That's high compared to the 4%, which is observed in people without heart failure. She then highlighted the fact that the risk of heart failure associated with diabetes is not exactly the same for type 1 diabetes versus type 2 diabetes. It turns out that risk, especially in relative term, is much higher, surprisingly, for type 1 diabetes than for type 2 diabetes. She mentioned a 3 to 5-fold high risk in people with type 1 when they're compared with people with no diabetes, whereas in people with type 2 diabetes, it's about 2 to 3-fold. And she also highlighted the fact that the risk of heart failure associated with diabetes is sort of much higher in women than in men. Now, the second speaker was Dr. Dale Abel from UCLA, and he presented on the mechanisms that actually drive the cardiac remodeling or cardiac dysfunction in the setting of diabetes. He highlighted the fact that one could conceive of the events that are happening in the setting of diabetes as being a combination of a metabolic disaster and a vascular disaster. He chose to sort of focus on the metabolic disaster and highlighted the fact that among people with diabetes, there's not just an elevation in the blood glucose level leading to glucose toxicity, but there's also a certain degree of lipotoxicity, and combined with systemic inflammation, and a combination of all those metabolic processes drive the occurrence of cardiac dysfunction. He illustrated the glucose toxicity by highlighting the activation of the polyol pathway and the whole glycination that happens in people with diabetes and drive cardiac remodeling. For the illustration of lipotoxicity, he showed some data from a transplanted patient where he highlighted the fact that, those who are transplanted hearts from healthy donor without diabetes, and when those hearts are given to people with diabetes, they end up on imaging and both also in histology showing a high degree of lipid accumulation. And so he pointed out the fact that lipid accumulation is happening in the setting of increased fatty acid oxidation, which ultimately leads to an increase in the reactive oxygen species, which are toxic. And all of that leads to mitochondrial dysfunction, which seems to be at the center of these processes, and with an alteration in the bioenergetics in the heart, with a shift in the substrate utilization from mainly glucose in the heart to the utilization of lipids and amino acids. And that's probably because of the background insulin resistance. And that insulin resistance is pretty, important in the myocardium. He then pointed out the fact that at the moment, we're still lacking data linking those mechanisms with the existing therapies. The third presenter was Dr. Ambarish Pandey from UT Southwestern, who sort of shared some data on the role of cardiac imaging for the identification of diabetic cardiomyopathy. He started by highlighting the fact that a significant proportion of individuals in the community have preclinical stage heart failure. And he was referring in this case to stage B heart failure, which is usually defined on the basis of echocardiographic abnormalities. And he highlighted the fact that stage B heart failure, which is preclinical heart failure, is a high-risk state because it's associated with a poor prognosis, especially in terms of mortality. And he showed data showing that the higher the number of echocardiographic abnormality on the imaging, the poorer the prognosis, and that one of the most important echocardiographic parameter in terms of the prognosis was the left ventricular mass, mainly, defining left ventricular hypertrophy. He then suggested that one could conduct an early detection of diabetic cardiomyopathy using echocardiography, and especially in if one could actually show that there's also an absence of other reasons for cardiac dysfunction, like hypertension, coronary artery disease, or valvular disease. And that screening could be done in combination with imaging, could be done in combination with cardiac biomarkers such as NT-proBNP and high sensitivity troponin, especially as in those with abnormal imaging parameters. If they also have high levels of those biomarkers, the prognosis is even worse. And he showed data on pool analysis from multiple cohorts in the US, whereby they evaluated among people with stage B heart failure based on echocardiographic parameters, the number needed to treat to prevent one heart failure event if one were to administer an SGLT2 inhibitor in that population, which in their study had a 70% high relative risk of heart failure. The number needed to treat was 37, and the number needed to screen to prevent one heart failure event when using an SGLT2 inhibitor was 60. And the 37 and the 60 numbers are actually suggesting that and such an undertaking of screening could actually be cost effective and could save a number of lives. The next presenter was myself, and I presented some data on the potential use of circulating blood biomarkers to predict or identify heart failure or cardiac dysfunction among people with diabetes. I started by showing some data on the traditional cardiac biomarkers, which are well known in clinical practice, like NT-proBNP and high sensitivity troponin. What I highlighted was that they are highly predictive of heart failure in the population with diabetes, but there's no significant difference in the predictive ability between those with diabetes and those in the general population. And I also show some data on markers that may have more specificity in the setting of diabetes, like GDF15, which is thought to capture the degree of mitochondrial dysfunction. And so ultimately, the observation with GDF15 is that although it may help to modestly increase the prediction in the setting of diabetes, that increase is so limited that we can't really operationalize it in clinical practice. And I then elaborated on the possibility of using data from small molecules like metabolites or molecules in the proteome. And regarding the metabolite, we discussed the possibility of using branched-chain amino acid for a more specific prediction of heart failure in the setting of diabetes because of the alteration of these amino acid in the setting of diabetes and the setting of heart failure. I then showed some data on some unique proteomic markers that were found in the ARIC study, atherosclerosis risk and investigation study, to be specifically associated with heart failure in people with diabetes and not in people without diabetes. And some of those proteins are from the SomaScan panel of 5,000 proteins. And among those proteins, a sort of very specific class of proteins, the semaphorin. The last speaker of this session was Dr. Boskurt, who showed some data on the intervention that could be used to mitigate the risk of heart failure among people with diabetes. She started by highlighting the high burden of preclinical heart failure, as previously already in the session mentioned by Ambrish Pandey. And she suggested that, those people could be actively detected by using a combination of echocardiographic assessment, cardiac biomarkers, NT-proBNP, and high sensitivity troponins, as it was sort of recently suggested in the consensus statement on the universal definition of heart failure. And then she then went on to elaborate on the therapies that could be used to mitigate the risk. And she suggested that when somebody who is at high risk of heart failure, meaning in stage B heart failure, is detected, sort of the base therapy could include an SGLT2 inhibitor combined with lifestyle modification. And all the additional therapy, cardioprotective or renal protective therapy, will be added based on the presence of other risk factors such as, obesity or a high atherosclerotic cardiovascular disease risk. In those cases, it will be appropriate to use the GLP-1 receptor agonist, especially given the results of the SELECT trial, the various SELECT trial results that were presented. And so it will be very useful to use a GLP-1 receptor agonist. And depending also on the renal risk, especially in people with type 2 diabetes and albuminuria or an alteration in the eGFR, it would be appropriate to think about adding an ARBs or an ACE, an ACE inhibitor, or also a mineralocorticoid receptor antagonist like Renal, and that will be sort of the cocktail that will be used in that situation. Maybe just to quickly summarize, the main takeaway that I will sort of highlight from this session is that diabetes and heart failure frequently occur together, so they represent a major clinical problem. And we are sort of understanding more and more the mechanisms that link the two diseases, but the therapies may not necessarily target some of those mechanisms, and those mechanisms can also help to think about a more refined prediction of heart failure in the setting of diabetes using metabolomics or proteomics. But this is not yet operational in clinical practice. But in the meantime, there is enough ground or enough evidence there to conduct screening using a combination of imaging and biomarkers, and applying the various treatments that we already have. And so now, thank you again. Now we'll turn it over to Dr. Khan for her to summarize the session.
Thanks, Justin. And this is a great kind of segue that links both your comments and Tiffany's comments about the presentations with the session that I'll be reviewing called A Confluence of Risk, Navigating the Intersection of Cardiovascular, Kidney, and Metabolic Health. And both Tiffany and I were speakers at this session. And the goal behind this session was really to start to or really continue the discussions around this confluence of cardiovascular disease risk among people who have obesity, diabetes, and kidney disease, and help to highlight the new cardiovascular kidney metabolic construct that the American Heart Association recently published. And we reviewed several of these publications, which include a presidential advisory, a scientific statement, and a synopsis of the clinical guidelines in terms of available evidence. And we heard about new evidence that was just presented during the sessions as well regarding novel therapies. Part of the impetus for this session was the fact that we know that cardiovascular disease risk among people who have obesity, diabetes, and kidney disease is quite significant. And often these risk factors cluster together. And there's this multi-directional influence whereby an individual is at risk for multiple adverse effects related to these. So the session focused on highlighting mechanistic pathways, pathophysiology, optimal therapies. We know we've had really an explosion of evidence for novel therapies that can be cardioprotective, such as SGLT2 inhibitors, GLP-1 RAs, non-steroidal MRAs. And they don't just have benefits for one of these conditions, where just in people with diabetes or just in people with chronic kidney disease, but these therapies have also opened up a new approach to reducing cardiovascular risk holistically for the whole patient rather than focusing on individual diseases. And lastly, one of the important things that we spoke about was the fact that these therapies have also really spanned disciplines. So we need to think about an interdisciplinary approach to care and not just what is the primary care doctor doing, or what is the endocrinologist doing, or what is the cardiologist doing, and how do we bridge those things together, but also stay cognizant of the fact that as newer therapies are available, disparities may widen. And so the session had a really quite a breadth and depth of topics covered across these areas. To kind of zero in a little bit more on some of the very specific things that were discussed during this session, it started with Dr. Julie Lovshin talking about mechanistic pathways that link metabolic dysfunction, kidney disease, and cardiovascular disease, and helped to highlight some of the mechanisms that may be targeted with the novel therapies. Particularly, we talked about inflammation as a key driver, especially when we're thinking about obesity, excess adiposity, and dysfunctional adipose tissue. Where are the deposits that may contribute to inflammation and metabolic and kidney risk? The next talk focused on what are the available therapies and what are the evidence for which we can use them to reduce cardiovascular disease risk. We heard about the SELECT trial, which I think one of the most exciting parts about this was that the fact that we saw cardiovascular disease risk reduction in a secondary prevention population that wasn't based on just weight loss. We know weight loss is an important mechanism through which GLP-1 RAs reduce risk, but we saw those curves separate early, as Tiffany mentioned. Talked about SGLT2 inhibitors and their potential specifically for heart failure prevention. And I think that tied nicely, Justin, with your session, really thinking about the co-occurrence of diabetes and heart failure and how those therapies may uniquely be utilized for heart failure prevention, as well as the non-steroidal MRAs and how they can be really applied in terms of guideline-directed medical therapy for individuals with kidney disease and how important that can be as additive therapy. The next presentation was the one that I discussed, talking about our new risk prediction equations, the predicting CVD events prevent model. This was unveiled during the session and had a simultaneous publication in circulation as well, where we derived and validated in over 6 million adults new risk prediction equations that estimate 10 and 30-year risk for total cardiovascular disease, as well as cardiovascular disease subtypes. So we also look at atherosclerotic cardiovascular disease and heart failure separately. And part of the reason that we wanted to broaden our approach to cardiovascular disease risk prediction and spoke about during this session was, as we've talked about, we know that the risk for cardiovascular disease extends beyond that for atherosclerotic disease. So heart attack and stroke are really important outcomes, but we're seeing an increase in morbidity and mortality related to heart failure that's highly relevant. And we now have therapies that can prevent heart failure and improve outcomes related to heart failure as well. The other key thing that we spoke about with the new risk prediction models was the inclusion of kidney function, or eGFR, in these models, again highlighting the importance of using that in risk assessment and prediction. Lastly, we spoke about the importance of removing race from risk prediction, but ensuring that the risk prediction models accurately and precisely estimated risk across subgroups and demonstrating calibration as well as discrimination in these subgroups that were good to excellent as well. We ended the session with Tiffany's excellent discussion about the importance of centering all of these discussions in terms of how we approach patients with cardiovascular kidney metabolic syndrome for their screening. If we don't screen, we won't know if someone has risk factors, for their staging to understand where on the spectrum they are, and for modifying or mitigating CVD risk, and centering that discussion and conversation on ensuring that there is appropriate access and that we don't widen disparities as we continue to identify new therapies and new approaches to prevention and improving the health and well-being of patients who have risk or have cardiovascular kidney metabolic syndrome.
Thank you, Sadia. If you could summarize the main takeaway from this session or the main activation for one's practice, what would that be?
Yeah, I think the session was really centered around the introduction and consideration of a more holistic approach to patient care, particularly for patients with diabetes who have risk for kidney disease and cardiovascular disease. I think the key takeaway is ensuring that we are quantifying risk for these individuals, whether that requires additional screening or testing, identifying the evidence-based therapies that are appropriate for their risk stage, and then identifying what the opportunities are to reduce that risk. So that's a more qualitative answer than perhaps a very precise clinical answer. But I think the novel therapies are really where the excitement was throughout the sessions in terms of cardiovascular kidney metabolic health, but really identifying the right patients for the right therapies and thinking about how we can equitably approach the dissemination and implementation of these strategies.
Okay, thank you again. And now I will take a moment to share some of the key findings from the Cardiovascular Kidney-Metabolic Syndrome Pathophysiology and Therapies, a road commonly traveled. So, and I think these sessions links very well to a session. There were a number of speakers on this session. The first speaker was Dr. George Bakris, who talked about how to navigate the overlapping comorbidities in cardiovascular disease, kidney, and metabolic syndrome, since this is seems to be the way to go. And I think he used a sort of schematic to summarize it, and I really love it. He sort of exhorted us to think about the heart and the kidney as a married couple and living in a house, and then the house is sort of the metabolic milieu, and that metabolic milieu will be construed as diabetes, and you can imagine that diabetes will be driven by in the background by obesity. And I really, it was a really nice way of summarizing the whole thing. He then went on to talk a little bit about the very high prevalence of chronic kidney disease in the US population, and highlighted the fact that the vast majority of individuals with some sort of kidney disease will die from a cardiovascular cause. And he highlighted the fact that when one thinks about the cardiovascular risk in the setting of chronic kidney disease, one should not just think about eGFR, one should also remember albuminuria, which is also a very robust and strong cardiovascular disease risk factor. And because of that, he then went on to highlight the fact that there's a certain degree of clinical inertia in code, because a lot of people use ACE inhibitor and ARBs in a suboptimal fashion or submaximally in today's clinical practice. He highlighted the fact that when it's used that way, it equates to not using those medications at all. And then he also highlighted what for me was an important clinical point, was that one should not refrain from combining SGLT2 inhibitors, medications that are used for RAS blockade or non-steroidal mineralocorticoid receptor antagonists affiliated on these days, because although they will all initially reduce EGFR, in the long term, they will be beneficial in terms of the cardiovascular disease risk protection. And he highlighted the fact that, as long as that reduction in EGFR is less than 30% and there's no hyperkalemia, that's perfectly fine. He then closed his talk by mentioning the pillars of therapy in the context of cardiovascular disease, metabolic syndrome, and kidney disease, which revolve around, a cocktail, as he put it. And that cocktail include medication that achieve RAS blockade, SGLT2 inhibitors, GLP-1 receptor agonist, and non-steroidal mineralocorticoid receptor antagonist. The next speaker in this session was Dr. Lige Oxen from Johns Hopkins, who presented some data on metabolic health using markers that were measured by SomaScan, which is a proteomic platform. And in this case, in this particular study of hers, they measured 5,000 proteins, and they were trying to identify the proteins that would predict, the change in metabolic health status over a 6-year period. And the metabolic health status could be improved or it could deteriorate over time over those 6 years. And they observe a 20% change in metabolic health in terms of worsening for people who were healthy to start with in the study, and 80% improvement in metabolic health for those who were unhealthy to start with. And the way they define metabolic health was on the basis of metabolic syndrome using the classical AHA and NHBI definition. And the SomaScan screen allowed them to identify 49 proteins which pointed towards a poor metabolic health, and 10 proteins which pointed towards an improvement in metabolic health. And those proteins had, surprisingly, as top proteins that are in carcinogenic pathways like VOPP1 and MXRA8, and those proteins seem to belong to a pathway, the tyrosine kinase signaling pathway, and pointing, she ended by pointing out at the fact that those could potentially be used in clinical practice for metabolic health prediction. The next speaker also presented on proteomics, which sort of follow elegantly from the previous presentation. And he sort of highlighted the potential application of proteomics to predict cardiovascular disease and kidney disease in people with diabetes. And the proteomic platform that was used in the study that he presented was also SomaScan, which can measure up to 11,000 proteins. And it's apparently the latest platform that they have, which is very powerful. And he illustrated the predictive ability of these proteins by showing two different models, a model for the prediction of cardiovascular risk over a 4-year period among people with diabetes, including 27 proteins. And the performance of that model of 27 proteins was pretty robust in different populations, about 10 different populations. The performance was between 0.7 to 0.8 in terms of the area under the curve. For the kidney disease prediction, he presented a 10 protein model, which was also highly predictive. It was better than one of the currently existing kidney risk equation, the kidney failure risk equation. The protein model had an AUC of about 0.8 versus 0.7 for the kidney failure risk equation. And he showed that when applied to the ARIC population, those two sort of protein models had very good performance. The next session was presented by Dr. Nguyen from MGH in Boston, and he showed data on the potential lifetime gain in cardiovascular, kidney, and mortality outcomes from using a combination of SGLT2 inhibitors, GLP-1 receptor agonists, and non-steroidal MRA, and in comparison to conventional care. And the estimates that he used to make some of those projections was derived from meta-analysis combining data from various clinical trials of each of those classes of medications. And then the results in terms of the projection, he showed the survival free of event estimates for every age between age 50 and 65, associated with the use of those drugs individually versus the combination of two of the classes that I mentioned, versus a use of the combination of the three classes, SGLT2 inhibitor, GLP-1 receptor agonist, and MRA antagonist. And so the highest relative risk reduction that he sort of presented was derived from the triple combination. And that triple combination in terms of the projection of event-free survival for a patient age, for example, 50, when compared to the conventional care, which is a use of RAS blockade plus, a control of risk factors using the traditional means, the event-free survival for cardiovascular disease was about 3 years. And for kidney-free survival, it was about 5 years, showing that there could be enormous gains from using a triple combination of among people with type 2 diabetes and high risk. And so the last speaker was Dr. Miller, who presented data on the effectiveness of icosapent ethyl IPE for the prevention of the first cardiovascular events and total cardiovascular event being a combination of both the first and subsequent cardiovascular events in people with metabolic syndrome in REDUCE-IT trial. Just as a reminder, the REDUCE-IT trial was a randomized, double-blind clinical trial where people were allocated to IPE at a dose of 4 milligrams daily versus placebo. And those were people with normal HDL, but with an elevated triglycerides. And in this particular study, Dr. Miller showed that, the use of IPE in people with metabolic syndrome without diabetes led to a 41% reduction in the risk of cardiovascular events, total cardiovascular events, both the first and the subsequent cardiovascular events. And in terms of the first cardiovascular event, the relative risk reduction was about 29%, and absolute risk reduction, and the absolute risk reduction was about 6%, corresponding to no needed to treat of 17. And so he also showed that various other sort of secondary outcomes were reduced. So that's about it for this session. Maybe just to sort of quickly summarize this session, the takeaway message from this session, I think the main takeaway message from a clinical perspective is that there could be significant gain in terms of prevention of both cardiovascular events and kidney disease among people with diabetes if one was to or were to implement a triple therapy using a combination of SGLT2 inhibitor, GLP-1 receptor agonist, and a mineralocorticoid receptor antagonist. So I think that's sort of the main message. So from this session. I will sort of move on and say thank you to all our panel presenters for a great discussion. Now, if you haven't already done so, please ask your questions for today's panelists by typing them in the Q&A box. If needed, when preparing your questions, on the slide is a list of the session discussed by each speaker today. As we gather the questions that have come in, I want to remind you to check out knowdiabetesbyheart.org, which is a website, which is a dedicated website, where you can find the latest guidelines, including the 2023 standards of care, as well as patient education research and interactive case study. Now, I'm just going to turn to the question. There's a question in the Q&A, and the question is from Michael C. And the question is, how do the reductions in relative risk of MACE with GLP-1 receptor agonists compared to the reduction in risk through achieving exercise recommendation, dietary modification, or other lifestyle modifications?
So that's a really important question, and it was actually a topic of discussion during the session. There's a concern that as we focus a lot of our attention on the novel therapies with GLP-1 receptor agonists and others, that will, especially in terms of obesity pharmacotherapy, that will lose sight of the importance of lifestyle modification in thinking about treatment, not only for obesity, but also for cardiovascular disease. But to answer the question, it really, we haven't seen from lifestyle interventions, we haven't seen the reduction in cardiovascular outcomes and cardiovascular events that we are seeing with the SELECT trial. But there has been data from post hoc analysis of the Look Ahead trial, which showed that for patients treated with intensive lifestyle interventions who had overweight, obesity, and diabetes, that those patients who lost 10% or more of their weight over the trial actually did see similar reductions in cardiovascular, overall cardiovascular events, and as compared to what we're seeing in SELECT. And so the question really is, how do we incorporate these medications into existing lifestyle interventions? How do we make sure lifestyle interventions are a part of all of our treatments that we recommend? And how do we make lifestyle changes easier for patients? Because we know that there's so many barriers to changing diet and increasing physical activity that patients have to overcome.
And Tiffany, I just wanted to add, I think that's a really great point, and it's a great question because the SELECT trial didn't offer lifestyle intervention, right?
Exactly.
They set it up to say it's not a weight loss trial. And so it was really the comparison of getting the therapy or not, but that's not really how we want to implement it, really.
Absolutely. Yeah. And we don't want that to get lost, that lifestyle is a part of what patients benefit from. And it's not just about weight loss. It is about the stress reduction effects that we know have cardiovascular and metabolic impact. It's about other mental health outcomes as well. And so it reduces other risks for chronic disease. So lifestyle interventions are key in what we do.
Okay, maybe 2 points to add to what you sort of highlighted. There's also evidence from the DPP, the Diabetes Prevention Program, which did not really include people with diabetes. Those were people with pre-diabetes. And I think the data from DPP it's suggestive that maybe lifestyle intervention may not be as good as GLP-1 receptor agonists in terms of preventing the cardiovascular disease. The sort of initial and the long-term follow-up of DPP, although these results are showing a trend towards a reduction in cardiovascular events, that reduction wasn't sort of statistically significant. Maybe just to sort of look at the other extreme, that the other extreme is the group of people with morbid obesity, and before the advent of the GLP-1 receptor agonist, the recommendation in terms of reducing the risk was to have them undergo bariatric surgery. So how do you think that the GLP-1 receptor agonists will compare in terms of their clinical effectiveness, in terms of their costs with bariatric surgery? Maybe Tiffany.
So another excellent question and great consideration in terms of bariatric surgery versus pharmacotherapy with GLP-1 receptor agonists. And again, another point that came up during this discussion, we already know that bariatric surgery is very much underutilized, and so the concern and thing that we want to prevent is that GLP-1 receptor agonists follow that path and remain underutilized as well. And again, that's where thinking about how do we maintain access or increase access for patients who qualify for a treatment with GLP-1 receptor agonists, but also how do we, the bigger question too is how do we increase access to treatments across the spectrum of treatment for obesity, including bariatric surgery. And so the amounts of weight loss that we see with bariatric surgery are right now are higher than what we're seeing with GLP-1 receptor agonists, but there are some that are now available that are maybe even comparable to what we see with bariatric surgery with the approval of Zepbound for treatment for obesity. And so we really need to think about how do we get more patients to bariatric surgery if that's what they are need for treatment, but also can we think about these medications as a part of achieving weight loss maintenance after bariatric surgery. And so I think one of the great points that Dr. Donna Ryan brought up during the session was the idea that we really need a much better and much more defined stepped approach to treatment for overweight and obesity, where we have clear guidelines in thinking about when do you start specific medications, when do you refer patients to bariatric surgery, how do we keep patients throughout this treatment continuum, how do we keep lifestyle interventions as a part of that. And I think that type of stepped approach is something we need to also think about in terms of treating cardiovascular-kidney-metabolic syndrome as well.
And Tiffany, that's like a really great way to think about, how do we just think about the patient's risk itself. SELECT was a great secondary prevention. So people who already had cardiovascular disease and showed a benefit, but among the primary prevention population with obesity, one of the things we spoke about at our CKM session was really about how do we use absolute risk with the prevent equations as another way to potentially consider stratification of patients with overweight or obesity who may have greater net benefit from some of these therapies if we look at what their absolute risk is at the starting point. So I think that's another opportunity where risk stratification and utilizing net benefit could give us an approach for who to use some of the therapies in.
Absolutely.
Yeah, maybe a question that is in the chat that is related to primary prevention. There's Sean Sutton, who is asking, as a primary care provider, I really want to try to prevent disease without medication. What are your thoughts on how we can do better with primary prevention of overweight or obesity and other health issues related to the overall lines on hyperprocessed foods?
Yeah, that's a really difficult question. Maybe I'll take a quick response, and then Tiffany, if you have anything to add. I think, Justin, you mentioned the diabetes prevention program. So really, we need to focus on implementation, whether that's at the community level, at the health system level, at the individual level, and really utilize a multidisciplinary approach to incorporating behavior and lifestyle changes with therapy if needed. And I think to the person asking the question, really starting at that earliest stage where we can do some of these health behavior interventions before therapy is needed is the optimal situation where we can either help people maintain ideal cardiovascular kidney metabolic health or help them regress back to optimal cardiovascular kidney metabolic health. But I think really investing in structured implementation of health behavior interventions that we know are successful, like DPP, or new research that can help us identify where those strategies are. And I think digital health has become a really wonderful platform to help support some of this.
And just to add to your excellent point, Sadia, the fact that we have so much access to hyper-processed foods really suggests that there needs to be more policy level changes to affect how we're accessing those foods, and especially I think younger populations who are developing these risk factors earlier and earlier. There is a role, and there's evidence to suggest that policies related to accessing and taxation of sugar sweetened beverages and those types of policy level tools, policies around diets in schools and what is included in lunches provided at schools. Those are policies that can play a role in addressing and serving for primary prevention over overweight and obesity.
Yeah, couldn't agree more.
Thank you very much. That's a great discussion. Unfortunately, as usual, we're sort of nearing the end of the webinar. So I'm going to sort of close by saying thank you to our speakers for their time and expertise, and thank you to each of you for joining us. Following this webinar, you will receive an email with a link to complete a brief survey. I encourage you to complete that survey and provide feedback and any comments for webinars and resources you would like to see from Know Diabetes by Heart in the future. We hope you will join us for other Know Diabetes by Heart sessions in the future. This concludes our program, and enjoy the rest of your day. Thank you.
Thank you.